Dr. Shore, thank you so much for meeting with me and sitting down for this conversation about skin cancer screening. Early detection is so important for saving lives. You know that I have been going to your clinic for years, and I have sent a lot of friends and families to your clinic because I believe in your thorough screening for skin cancer. So thank you for coming in today.
Thank you very much, and thank you for the opportunity to provide more information on the value of doing this.
So you run a highly successful screening program for cancer research over the last 30, 40 years. Tell me about it. Any particular lessons you can share?
Many lessons, and these have pertinence not only to dermatology, but to other fields as well, using early detection to save lives. A little background. When I was doing my residency training in dermatology, the head of the research division was perhaps the most famous research dermatologist in the world.
What's his name?
Albert Kligman. He developed Retin-A and cosmeceuticals and so on, using retinoids for wrinkles and all these sorts. And he was very well known. And he would also arrange for speakers to come to speak to the residents. And he was all excited one day because I'm getting a person named Wallace Clark to come in. I'd never heard of him before because I was just new at that time. And he was all excited about this. So I thought if a person of this eminence was excited about someone else coming in, he must be good. And I remember him being all excited about this after many, many years. And so Wallace Clark came in, and it was worth the notification, and I was very impressed as well. Wallace Clark had developed a description of how the different types of melanomas and how they evolved. And he described what's called a radial growth phase, where the early stage, where they just grew on the surface, they could not metastasize, and they were 100% survival. Mm-hmm. And then most melanomas then went and they got the ability, they evolved, they got the ability to grow deeper into the skin, and these were later shown to be changes, various molecular changes and mutations and so on. And eventually,
melanoma can be deadly when they metastasize.
But not in its early stage, And there was one exception, and that was a type of melanoma called nodular melanoma. And nodular melanoma, for some reason, was only discovered in its late stages, and it didn't seem to have an early stage. No one could figure it out, and this didn't make sense to me. How could you appear?
Even today?
Even today. We think we have an explanation of how it happens. You hear of cases, for example, a person's, and we have patients all the time coming in, Mr. Jones, why are you coming in for a skin check? Because my brother died of a melanoma. He was fine, and then suddenly something showed up on his back, and he went to the doctor, and it was a late-stage melanoma, and unfortunately he died. His impression was this thing just showed up literally overnight, grew quickly, and killed him. And that story, I hear versions of that story I hear all the time. And so it appears
they probably missed a lot of warning signs for early stage.
Except there are no warning signs.
No warning signs.
The early melanomas have no symptoms. They don't itch, they don't bleed, they don't hurt, they're silent.
They could be a mole. They could be a little skin bump.
They could be, but they're not noticed by the person. People tend to notice. In men, they're most commonly on the back, so people don't pay much attention. They have no symptoms until that point. And then by the time they have symptoms, people, they may be more advanced and may have already metastasized.
And that's too late.
And the prognosis goes down. And so the question is, do melanomas actually just suddenly appear overnight and do that? And that was described more than 50 years ago, and no one has come up with a better explanation. In our skin check program, which I'll talk about in a few moments, we've been able to learned how to detect melanomas in the early stage. And we do that with all our patients. And interestingly, we're now in our 34th year. How often do we see a case of this nodular melanoma develop in practice? And the answer is 0. we don't see it.
So how many patients, or I should say, how many people you have seen in your practice over the 34 years?
Thousands. We know we've done at least 28,000 skin examinations. We've had over 6,000 skin cancers. These are not all melanomas. These are basically basal cells, squamous cells, the less serious ones.
So let's get back a little bit. For skin cancers, how many types of skin cancers we have out there, and what are the most malignant?
This is not just my view, but it's generally accepted. There are three most common by far. The most common is called basal cell cancer. It's the most common and the least serious. It's very rare that anyone dies from it unless they totally ignore it or things like that. The second most common and more serious is squamous cell carcinoma. Both of these are related to sun exposure, but now some of the newer drugs that are used, in particular for the cancers, predispose the body to squamous cell carcinoma. And the third most common is called melanoma, which is a malignant mole, and that type has the greatest risk of dying, particularly if you catch it late. But if you catch it early, everybody survives. That's not really well known, but that's in fact true. And our Skin Check program was formulated by, what if we caught everything early in the earliest stages as described by Wallace Clark? Maybe we could save everybody. And so we took steps so we would try to catch everything early. How did we catch everything early? And the answer is we asked patients, we did thorough exams. So if there was anything, we would catch it. And we're known for our thorough exams. And so I know from my reading that sometimes some exams, doctors say, well, we won't do the legs because that's not such a high-risk area. Not true. But the fact is they've left out an area. Most people don't have a melanoma, they'll get away with it in most cases, but if they do that routinely, sooner or later something's going to show up they missed. So thorough exams combined with getting patients to come back at least once a year and ideally every 6 months.
Even for people they think they have no issue whatsoever, you recommend them to go and do the annual checkup? Or maybe there are certain populations that are at high risk.
That's correct.
That should be doing the annual checkup.
Right. There are people who come in, and when I initially see them, and I think, well, this person doesn't seem to be at particularly high risk. And then when I get more information, most of those people who come in do have factors. Maybe there's a family history of melanoma, or they have highly irregular moles, or maybe they did things in the past like...
Or they get exposed to sand too much.
Right, too
and
much
they
sun,
love wilderness and beach.
Outdoor occupations or things like that, which would make them more vulnerable. So going back to your earlier question, not everyone needs these exams, but certainly people who have these risk factors. I think the most important would be a history of significant sun, particularly sunburns, and also have irregular moles and lighter complexions. People with darker complexions are less vulnerable, but not immune to it. So
right, and then when they do get it,
right.
they tend to be more malignant, right?
Not more malignant, but more likely to die. In other
more
words,
likely to die.
So
what's the difference?
Okay, a melanoma evolves from less serious to more serious. If you catch it in the early, less serious, 100% survival. If you catch it in the late stage, we hope for the best. Okay. But people who have darker skin types often, that's nothing. Ignore bumps, because there's a lot of benign bumps that show up over time. And by the time they take action, it has evolved to a more serious thing. So it's not that their melanomas are worse, but they're detected later.
I see. So it's still part of the screening and detection issues we are talking about.
Right.
Even for darker skin population.
Right. But I don't think there's the manpower, woman power to screen everyone, but I think the important issue is people who are at risk. And interestingly, there is a bit of a problem because a lot of people who are at high risk don't know it. For example, the highest risk group are older men who have had a lot of sun exposure in the past. And in the past, when they were younger, there were no sunscreens. And so
Correct.
these individuals don't know about getting a sunscreen.
And still, a lot of people don't use the sunscreen right now.
That is also true. That's another problem. You would think that the incidence of sunburns would have dropped off dramatically. Nope, plenty of sunburns all the time.
Your office was always more busy or busier after the summer, right?
Well, sometimes these things show up. I mean, we treat sunburns as well, but sometimes if a person gets a skin cancer, it shows up decades later, not necessarily, and not usually right after a sunburn or something like that.
Right after. Good to hear. So they actually have time to interfere.
Right.
The trajectory of the cancer.
Yes.
Right?
So what we recommend is people who are at higher risk. They have lots of moles. They have had a lot of sun in the past, so on. And we tell them this to get their skin checked every 6 to 12 months. So by doing that, as a skin cancer, if it occurs, let's say we do examine, everything's fine, and they get a skin cancer theoretically the next day, and it grows as fast as possible. We still should be able to cure it if they come in 6 to 12 months. But the problem is people don't listen. I have some patients there like clockwork. They come 6 months to the day. I have other people, I tell them every time you should come in more often. Well, nothing bothers me. And the message for those people is nothing will bother you in the early stages. So I think that...
Have you lost any patient that you either missed the early sign of skin cancer or they refuse to take advice? Those are two types of patients,
The
right?
answer, in people in the skin check program, no. It's possible, and maybe probable. At some point, I may have missed something, but when they came back again, I caught it then, and still was early enough. Okay.
So you mentioned early on you have done 28,000 skin screenings. 6,000 you found them to have early
6,000 cancers.
cancers,
Over
and
6,000.
you get them out, and those patients no problem.
Correct. And here's an interesting phenomenon. Like sometimes you hear of people who get a cancer, they go on a drug or a treatment, and they seem to be cured, and then tragically 2 years, 5 years later, it recurs. That never happens in people who catch it early, because we've caught those cancers in a stage where they're not capable of evolving into more serious, resistant cancer cells.
And you also mentioned within those 6,000 cancer patients, you interfered or intercept early stage.
Correct.
200 of them are melanoma patients.
Over 200 were melanomas, right.
And then they...
Almost all the majority were, they call insight to the earliest stage, where we expect 100% cure.
So in a way, you haven't lost any patients due to this kind of a program.
Haven't lost. Now, we've had people who walked in the door, never saw them before, who said, I have this big lump here on my arm, which was a late-stage melanoma before I even got to see them. And those, we've had 2 or 3 people in that category who did not survive. But they had already spread before we ever got to see them.
Right. You have no opportunity to even intercept.
Correct. But people,
influence.
we've done a skin check, everything is fine, and we've not lost any of those.
That's amazing. That's amazing. Haven't lost any patients with all the patients that you screened. Is this kind of program you set up widely practiced in U.S.?
I don't think so. I think we've published, I've made presentations internationally about this, but unfortunately it hasn't been picked up by, as far as I know, and I'm basing it by other medical papers and so on. And I think that I'm trying to get the message out, particularly to other medical people. I think family doctors, and internists, but certainly primary care physicians should be taught this. Is what we're doing teachable? And the answer is absolutely. We've had 5 physician assistants who have seen patients in our office, have been trained, and they haven't lost anyone either. So it's not that I'm the only one who can do this. It's a teachable procedure, and I think there are 2 important elements. One is performing a thorough exam and knowing how to do that, and knowledge on what some of these unusual cancers look like.
So
and two, getting patients back. This is the tough one. Getting patients back in a timely manner. I give the speech to them every time. You may be aware of that yourself. I keep on saying importance of coming back every 6 to 12 months because things can evolve over time, but that seems to catch everything or give us an opportunity for us to find it.
We as a nation, we have implemented this annual checkup for breast cancer, mammogram. People actually follow that regular routine checkup. But the two regular checkups I thought people follow is the mammogram and the pap smear. And those much harder to do than regular skin screening checkup, right? So why do you think skin screening checkup is so hard to be adopted by general population?
I think that right now I see to be to some degree a voice in the wilderness speaking out, and other people may say, well, what we're doing is okay. I think there's other things that could be modified. People are doing things the wrong way, they're used to it, and I'm basically trying to be more thorough, so a more thorough exam.
So you are talking about the doctor side, on the physician side.
Right.
Either it's a dermatologist or family doctors.
There's dermatologists, there's family doctors, and there are patients. Let me talk about each one. We have learned to recognize atypical melanomas. So if you're familiar with melanomas, how to recognize it, they speak of the so-called A, B, C, D, E signs. Each letter stands for a feature, A for asymmetry, B for irregular borders, C for color variation, D for a certain size, and E for evolution. Except, and it's melanoma month, or in May, they'll always interview some doctors. Dr. Smith, what does a melanoma look like? And I will tell you exactly what they're going to say. They're going to say the A, B, C, D signs and then close their mouth. That describes about 3/4 of melanomas. But there's a 25% that they don't identify. We've learned to recognize those 25%. They look nothing like the A, B, C, D signs. So it's like you might be used to seeing a certain thing and you're missing something else. And the person may be doing a good exam in some of these other irregular ones. We're actually in the late stage of reporting a paper what these things look like because they are recognizable. And I think by doing that their success will increase. This is for dermatologists. Family doctors don't have the training. They may have had a month of dermatology during medical school or something like that, but they don't have enough knowledge to do a good exam. And unfortunately, sometimes they may see something which is, I would say, that's a classic melanoma, and they think it's fine.
And the patients, trust their family doctors. So when they heard this comment, it's fine.
I think
and
the average primary doctor doesn't have enough knowledge. They have some knowledge. Obviously, something is highly abnormal. They will normally detect it.
Right.
But there are things that are more subtle that, unfortunately, they're not familiar with. I think a lot of cases where there's any question, they're referred to a dermatologist. But sometimes just asking a patient to do a skin check, recognizing who needs it, who doesn't need it. I think some of that information could be transmitted to family doctors. I could perhaps do that with an opportunity.
Are there any easy to read literatures or chart or graphics that you can put together or anybody put together to educate some of the dermatologists or especially young dermatologists or family doctors, family physicians?
The basic problem is there are not enough dermatologists for the people who really would benefit from it. So,
not enough dermatologists.
Not enough dermatologists. And there's maybe 15,000 dermatologists in the United States, and we have more than anybody else. In some other countries, they have far less. So I think this needs to be taught to other doctors. There is teaching, but I think a bit needs to be more thorough, and I think and some of the steps we've discovered, how to catch them early consistently is very important. If a person comes in, let's say a person just comes in routinely, you're going to pick up what happens by chance. A person might say, I have this spot here, and it's early melanoma. They make it. But what if it's not? They may not make it. And we're basically working things out so that everything we catch, virtually everything, that's almost been the entire story, is very early stage. And
so you mentioned 75% of the melanomas are easily detectable by majority of the dermatologists.
Correct.
And only those
based on the ABCDE signs, right?
Yes. And then those 25% of the cases are not easily detectable.
I'd say 15 to 25%,
15
right?
to 25%.
Do not have those features, correct.
And do you think the learning you had to detect those 15 to 25% cases can be transferred to other dermatologists or even the family physicians?
Right. I think it can be and it should be. We've taught that to the 5 physician assistants I talked about. We trained them to recognize those things.
And what's the barrier for us to get this learning spread out?
It's hard to sometimes reach people and spread the information. I've often thought of cancer, someone will be a big breakthrough cure, and what if no one will listen to that person, I could see, for example, let's say a person invented, we never had vaccines, and in 2025, someone invents a vaccine and says to a journal, I have a new treatment for infections. Well, no one's ever done this before. Yes, but it's new. We have to adopt it. We're not interested. I mean, I think it's new information.
But this is not even new. You've been in practice for 34 years.
But people haven't followed the way I would like them to. I mean, I would like them ideally to get this message across. I think it has, certainly in other countries outside, it needs to go to family doctors, primary care.
Yes.
And I think it could be taught. It's not like you have to study for 10 years to do it. I think it could be taught relatively quickly what to do, what to recognize, and I'm hoping sometime I'll be able to, in some way, be able to spread that message to these individuals.
Have you been able to outline those signs and in a easy to read piece of flyer, let's say one pager, things like that, or on the website?
I wouldn't say on one page, but I would say that we have published. We're running a new paper, which is, I think, intended primarily for dermatology because some things that they would not routinely know.
Right.
But I think this could be put together relatively simply to educate doctors. The highest incidence of melanoma in the world is in Australia and New Zealand. And they have, compared to the United States, have far fewer dermatologists. And the ones they have there are very good. But I think there are certain things we've learned that I think would tend to help those doctors. And I'm talking primary care doctors that are in Australia.
We could learn a really good lesson from breast cancer campaigns, public education, prevention education about self-check, self-exam for breast cancer, and annual mammogram. And I think the message you are sharing here could be important. Utilize the public, let the patients push for the doctors to do more general thorough screening checkup, and then at least for this type of populations, if they are more conscientious about going to the doctors, and then the doctors do a better job for them, I think we save good portion of people from skin cancer.
I think you're absolutely correct, but let me make a few comments about self-examination. In recent years, and I think it's the wrong approach, and I'd like to modify it. And with various handouts, it says you should get mammography and should get your PSA test, etc., and do self-examination. Okay. I think, and it doesn't say go, it may just say self-examination. If you see something, go to the doctor. It may not even say go to a dermatologist or someone who's knowledgeable in this area. Okay. So the problem with that is patients are not dermatologists. They may look at something, I don't know what it is. and don't know if it's important or not. And by the time if they've noticed it's grown a lot or changed a lot, it's late stage, and the likelihood of cure has reduced from 100% down to wherever they go. Younger patients are getting the message. There has been a significant decrease in skin cancer deaths in younger people.
Why do you think that's a reason?
I think two reasons. One is because people are coming in for more exams. We see people quite frequently in their 30s. They have risk factors, but they're not nearly as high risk as people in their 60s, 70s, and 80s. And they're aware they should get skin checks. And I asked them, why do you come in? Because such and such and such and such, and those are valid reasons for getting a skin check. Right now, if you look at the latest statistics comparing now to, say, 15 years ago, the incidence of cancer deaths has declined in younger people, but not in the high-risk group of older people. The message has not gotten through. I think maybe older people are not as aware of certain exposures and things like that.
Yeah, maybe goes to your earlier point. When people were younger, they were exposed with strong sun exposure, and it took decades to show up, right? For a younger generation, my son in his 20s, I remember from early years, when he was little, we always put sunscreen for him when he went to swimming and playing outside. So you're talking about 20 years of awareness from my generation and the younger generation. So maybe it's now you see the generation above me getting the impact right now from their earlier exposure.
The important point, you're correct. The important point I'm trying to make is that older individuals may come into the office and say, I noticed this, and sometimes it's a serious skin cancer, but they notice it in the later stages. That's when the cure rate's not nearly as good. They don't. How often do older patients show up and say, I'd like to get a skin check? They don't realize the value of skin checks. Okay. Some people will not come in and say, if I have cancer, I don't want to know it. But they don't realize that if you catch it early, everyone makes it. Everyone survives. So by delaying diagnosis, and we did a recent study, one of the messages that has gotten wide attention is self-examination of the skin. It's hard to do. In men, the most common site is the back for melanomas. And to examine your back, you have to use a mirror, and your eyes are basically about 4 feet from the skin. If I were examining you from 4 feet away, I couldn't do such a good job. So it's hard to see. They don't know what you're looking at.
Correct.
And so on.
Yeah.
So self-examination. And so
not very good for skin cancer.
We did a recent study based on 8 years of seeing patients. We looked at 8 years. All the people who had early melanomas, these are ones that all the patients we had seen in the practice, they have some education in terms of what to look for and so on. And the question was, how effective were they at recognizing a melanoma, an early melanoma, if they saw it? And so if they came in and said, Doctor, sure, I see a bump here, I'm worried it might be a melanoma. If it was, they get credit for finding it. If they came in and said, everything seems fine to me, and I find a melanoma on their back or a leg or someplace, I get credit. So we found all the melanomas. The question is, how many melanomas did the patients detect of all these melanomas? And the answer was about 1 in 5. That means 4 times out of 5, when it was early, easy to cure, they didn't know it. And if they hadn't been coming in and we looked them over, so the message I think is, I think professional exam has been downgraded. People say, do self-exam. It's not so effective. It will work, but it'll detect it later when the outlook is not so good.
I agree. It is much more challenging for self-exam for skin cancer, especially like you said, back of on your back, lower legs. People don't pay attention, and much easier to do a self-exam for breast cancers.
Right.
I lost my cousin, very young age, 31 years old, to melanoma. You would think, I always assume in our case, that young darker skin, her chance of getting melanoma is very slim. The strange thing is that mole was there for a long time until she got pregnant and started to grow. And after she had a baby, it got bigger and bigger and started to bleed. That's the time she went to check. It was already late stage melanoma.
I suspect from your story that the melanoma was there before the pregnancy and the hormones maybe just encouraged it to grow. A lot of things grow besides babies in skin tags and moles and various other things grow during pregnancy. I think this may have been a stimulation to that.
So exacerbated,
right,
the hormone change
if it was
exacerbated
caught shortly
the
after pregnancy, it had likely been there more than a year, probably much longer, but it could have been a melanoma. It could have been an irregular mole that became a melanoma. Then she became pregnant, and that sort of pushed it to grow faster, more severe.
So do you recommend people to look at their moles regularly and to get it out, removed the mole, just to eliminate the potential for those benign mole becoming malignant?
Most moles do not need treatment. Many years ago, a plastic surgeon had the concept, if I removed all the moles, I would reduce the rate of skin cancer. It did not turn out to be valid. Okay, very few of all the moles, a person may have a couple hundred moles. Of all the moles, very few become cancerous. I've had some patients who've had 3 or 4 melanomas over the years at different times, but people have many, many more moles. Most moles do not need to be removed. We look at them and why would I be concerned about a mole? If it was very dark in color, a particular part was dark and part wasn't dark, that suggests something may be changing. And that would be particularly true in a person with a lighter complexion. People with darker complexions often have very dark moles, and it's really not that significant. But people with a light mole, if they have a black-colored mole or a partly black, I'd be a bit more concerned. High irregularity. If you look carefully at moles, in most you can find some little detail. It's not perfect circle or oval or something like that. But if it's highly irregular, it doesn't have to be smooth, but most moles are. But the shape is irregular. It looks different from the other moles. There's a term called the ugly duckling sign, where something stands out. It's different from all the rest. And those are often skin cancers because they're so different from everything else. So a person, let's say, has lots of moles, but one looks quite different or it's changing, that they should go to the dermatologist for evaluation.
That's quite a good tip. So if you have to do a public service broadcast about skin screening and early detection, what would be the 5 tips you give to people?
Okay. When I tell my patients myself, the 2 most important things are, and I'll give you 3 more things after that. 1 is a thorough examination by the doctor. And
annually.
At least once a year. This is in higher risk people. I don't think a person who is a 10-year-old child with very few moles, no problem, hasn't been that much time. I don't think unless there's some other thing in the history I don't know, it doesn't need an exam. But as we get older, the risk goes up. Certainly with age, that's a significant risk factor, particularly after the age of 50. But most people don't need it. But people who have irregular moles, sunburns, suntan parlors, other things that could increase their I would say yes, at least once a year. Now, the figures are based, they've been done, often it says once a year, but in fact, some people who are at higher risk, we say every 6 months. That would be ideal. So if something changes, we catch it very early when everyone can be cured. So the first thing is a thorough exam by the doctor. And patients...
By dermatologist.
By a dermatologist. There are a few family doctors, primary care, who have extra training and can do that. And particularly in countries where there are not that many dermatologists, many of those doctors have learned to do that because they don't have a dermatologist to rely on to do that. But so people who know what they're doing are well trained on that. So a thorough exam by a knowledgeable doctor. Number 2, timely return for examinations. That's the 2. So come in ideally every 6 to 12 months And patients are not very good at doing it. Some are wonderful. They're like clockwork. But other ones, you have to call them. We send them reminders routinely every 6 months to come in. And there are some patients we had who are very high risk, who I had not only send reminders, I had to get on the phone and talk to them. And Mrs. Jones, you haven't been in here for about 2 years now, and I was a bit concerned about some of your moles. Nothing is bothering me. And I had to explain again that it won't bother you in the early stages. It's when when you start having symptoms, things are probably not so favorable. So getting people in, and I even made some house calls on rare occasions to take care of these. But patients don't appreciate the value. Some people do, but I think the community does not appreciate the value of doing ongoing examinations. If it's done well, the results are fantastic. And as I've indicated to you, we've had this record of over 30 years, no deaths from any new skin cancers.
And what are the other 3 things?
Okay. I would say use sunscreens on a regular basis. If you're in a lot of sun. I sometimes tell my patients in winter months, I come to the office, I park my car in the parking lot. Before I enter the building, I get maybe 10 seconds of sun. At the end of the day, I get 10 more seconds of sun. I don't need a sunscreen. You don't have to use sunscreen year-round if you're not getting exposure. But definitely in the summertime, if you're going to be outdoors taking a walk or even spring and fall out for an hour in the sun, definitely use a sunscreen. Sun damage is cumulative, and take measures you don't get sunburn. Sunburn is particularly important to avoid. That correlates with increased risk of melanoma.
What what brand of sunscreen products are your favorite?
I don't go for a particular brand. I like the higher numbers. Number, I would say, go with at least a 50, and there's no harm going 70 or 100 too. You're reducing the amount of added sun damage. You keep on getting sun. It builds up. It causes not only increased risk of cancers, but wrinkles. Sometimes telling people it causes wrinkles is more significant than it causes skin cancers. But wrinkles and other changes in the skin, increased risk of bruising.
So that's the third one. What's the number 4?
Okay. If your father or mother has, you can see they have a lot of sun damage. You can tell that by various growths on your skin and so on. Get them to go to the doctor. They don't seem to have the message that skin checks are valuable. Say, well, nothing's bothering me. They keep on saying that, It won't bother.
Get your loved ones to the dermatologist
to get their skin checked. If you can see the sun damage in front of you and you know they've had a lot of sun in the past. And when they grew up, there were no sunscreens. The first sunscreens became available in the late 1970s, and even then they weren't very good.
And you like the quality, the protective effect of current sunscreen products?
They're getting better. I think some of the ones they have in Europe are better than the ones here. But I think just due to regulations, what can be allowed or not. There's been some question about whether some of the chemical sunscreens can cause problems. There's chemical sunscreens and there's physical blockers. So some people, if they have any worries, use what's called a physical blocker, which is usually the key ingredient is zinc or titanium. If you have any question about these chemical blockers, they're still in the market, so I think the risk might be very low if so, but if you have any questions, use one of these physical blockers, and they're up to about 50 to 70 now.
And do they really protect you from sun for 50 hours? I always wonder.
No, it's not how many hours they protect you. I think it's like the higher the number, the less sun that gets through.
Oh, it's a percentage.
Yes.
Okay, that's such a misconception, at least even for me.
Right.
I always thought that was measured by hours, so it's not by hours.
Some people said, is 100 sunscreen any better than a 50? And they did a study, and the answer is yes, it is better than a 50.
So, I think people don't necessarily know what those numbers are. So a lot of times think it was the hours of protection.
No, not at all, not at all. And
It's
if you're in a situation where you might be swimming and use a towel and wipe yourself off, you should reapply it again.
Interesting. That's the percentage of the sun getting through.
Yeah.
That's an important message.
Yeah.
Maybe it's just my ignorance, but I think people around me tend to think
I
that's
remember
the hours.
Years ago,
Yeah.
there was like in various cosmetics, they had 15 and 30 sunscreen. And some people were arguing, well, we don't want to go too high. There's no harm in going higher with the sunscreen. So I would say the more the better in general, unless we find something theoretically down the road that indicates there's some problem. But that, if so, we should take the sunscreen off the market. Okay.
What's the number 5 tip?
Number 5, I guess if you see something that looks totally different from what you've had before, go to the doctor, even if you're not scheduled to
Immediately. If you see something irregular,
a dermatologist.
go to your dermatologist immediately.
Right.
Yeah.
Well, immediately doesn't mean you have to show there in 24 hours. But
at least don't put it out for weeks or months.
Okay, if the doctor says, I can't see you for 6 months, go to another doctor.
Right, exactly. Then,
Right.
well, this is a pretty common phenomenon now. You can get to see your doctors quicker.
I know, okay. I think there's been, unfortunately, a tendency to, if you have a cosmetic problem, you need Botox, we can see you tomorrow. But I think medical, sometimes they get later appointments. We will see patients within a day or two if there's something like that occurs.
You are very special, Dr. Shore. I go to your office. I have that feeling of trust. I know you will do a good job. That's why I refer a lot of my friends to go to see you.
Thank you.
Very special clinic. You mentioned earlier that there was showing the doctor's screening doesn't save people. You mentioned the paper. So if you could explain that what that paper is about and where it was giving the wrong message.
Okay. It was not a paper. It was a paper because it was published. It's every 5 or 6 years on various topics. The United States Preventative Services Task Force issues a paper indicating what they think should be done in screening. They make recommendations. And what they don't emphasize, and you may not even see it in the paper, is their recommendations are for primary care physicians. And they will say, and the latest one said, we can find no evidence that skin cancer screening is of value to save lives. But they don't say when done by primary care physicians. There are 4 papers, including our own, done by dermatologists which report 100% success. The other papers nowhere near as long as ours. And ours is still ongoing. But the people who, a primary care physician might read this and say, well, I guess I used to do some skin checks, but I guess it's not worthwhile. And not only doesn't do it, but doesn't refer to a doctor who is knowledgeable. I think that recommendation has been misinterpreted, and we need to get a message out that, in fact, and particularly what we've shown, it's not only protective, it's spectacularly protective. I mean, it's literally a cure because everyone who's coming in getting regular, thorough exams in a timely manner, if they got a skin cancer, was cured.
Why do you think that agency used the data from family physicians and not the dermatologists, not the specialist?
Okay. The United States Preventive Services Task Force is an organization set up by the government to evaluate for family doctors or primary care physicians. That's what I think they should at least, and they don't, as far as I know, distinguish this recommendation is for family care, not for dermatologists. It's not a general. They didn't say that, but people may read this and say, well, it's not recommended. There's no evidence it works. What is the evidence? And I contacted him. I said, I'll show you the paper that we've shown. If you do it in this way in thorough exams, you get wonderful results. They're not interested in that.
So it's you are asking the wrong questions and you are generating wrong data. It
That's
leads
correct.
wrong
That's
conclusions.
correct. People getting the wrong message.
Garbage in, garbage out, right?
Right. Many people read this and their interpretation, skin cancer checks don't work.
Yeah,
In fact,
I agree
not only
with
do they
you.
work, they work better than anything else. Haven't seen any other screening reporting 100% survival.
Well, Dr. Shore, I hope this conversation will get your message out. We hope the listeners can take action and at least get them to think about these issues, especially in the hot summer. So thank you so much for your care,
Thank you
for
the
patience.
opportunity for helping me get the message out to people.
Yeah, it's our mission to make sure people actually know what to do to prevent.
It's my mission as well.
To prevent the cancer and then detect cancer early, and eventually people don't have to go through treatment.
There are so many advantages of early detection: reduced morbidity, reduced expenses, and reduced anguish and things like that.
Thank you very much, Dr. Shore.
Thank you very much for having me.